Hemolytic uremic syndrome is a triad of hemolysis, your acute kidney injury, and thrombocytopenia. Most often it was due to once upon a time due to the diarrhea, Shigella, dysentery, and E. coli various types. But nowadays it is not the post-diarrheal or post-Shigella. Rather, it is a wide variety of the other disorders like your infection, pneumonia, your drugs, cytotoxic drugs, clopidogrel, and your anti-cancer drugs, and your contraceptives. So, a good amount of time we do not know the cause. So idiopathic, and this and there is good deal of overlapping diarrhea positive, D positive HUS, D negative HUS. You cannot call it nowadays straight way because there is a good deal of overlap because the presentation is D negative type. Patient do not have any history of diarrhea or dysentery, or on the other way, the D positive diarrhea positive is there, but the presentation is different. So it is possible that there's overlapping call type. And how do you diagnose? The apart from the stage 3 hemolysis, all of a sudden a patient turned pale, normal patient or turned pale following a diarrhea or any other precipitating events, pneumonia, and at times it is due to the your other agents like the chemotherapy agents, your oral contraceptives, your oral intake of the the lipid lowering agents, blood thinner, what you call clopid. So ultimately, presentation is hemolysis, sudden pallor, renal shutdown, acute renal shutdown, no urine, oligonuria, hypertension, edema, and dyspnea. And can be the little bit of an other organ involvement like CNS loop, and can have the pancreatic involvement with the diabetes, and good amount of time you have other organ involvement. So like your heart, cardiac involvement. So wide variety presentation, sudden pallor, you have diagnosis of typical or atypical HUS. Nowadays atypical one is more common, that is D negative, previous D negative one. So do investigate them with creatinine, with blood film, and diagnosis of the triad. And finally extent of the disease by organ involvement in heart, diabetes, your CNS, and gut, at times perforation, toxic megacolon, dilatation, perforation, all are possible. So investigate in that way, refer this patient to appropriate place, to a nephrologist, pediatric cases to pediatric nephrologist, adult one to adult nephrologist. They might need the blood transfusion, other supportive measures, and may need dialysis. Finally, your the genetics is underlying genetic cases, your good amount of time, the your factors involvement is there, B, C, and others. So age and age related protein deficiency, and they are controlling genes are there. They are also diagnostic. At the same time, the genetic diseases, the discoagulation, the dysregulation, they need lifelong, maybe good amount of time, the treatment of eculizumab along with these supportive measures, and prognosis of those cases who long-term treatment is needed, and maybe a little bit guarded and expensive also, but they need referral to appropriate place and person.